Well, good morning, everybody. I'm Jeff Gold, and I have the honor of serving as the Chancellor of the University of Nebraska Medical Center. I can inform you now that we are presently treating the second patient infected with Ebola virus here at the University of Nebraska Medical Center and the Nebraska Medical Center Biocontainment Unit. Our patient arrived in his room a few hours ago directly from West Africa and is now undergoing preliminary evaluation and tests to determine his condition, and those tests will ultimately help us plan his therapy. Mr. Mukpo is already receiving care to fight this disease. Here at the University of Nebraska Medical Center, we are honored and humbled to again have been called upon in a time when many are fearful about the spread of this disease. Indeed, it was last Thursday that we first became aware, and through some ongoing communication Thursday and Friday, the decision was made late Friday, and the transportation occurred over the weekend. We are proud to offer our assistance to work closely with the national, the state, the regional public health leaders to assist in the care both within our country and through telecommunications around the world. The Nebraska Medical Center Biocontainment Unit is one of the safest places in the world for Mr. Mukpo to be. But it is also one of the safest places in the world for our team of highly experienced healthcare professionals caring for him, for his family, and for the general public. As with our last patient, we can assure you that every possible measure will be taken to ensure that Mr. Mukpo receives the very best care and treatment that modern medicine has to offer, along with a signature dose of Nebraska niceness and hospitality for him and for his family. Joining us today on the panel is Dr. Ali Khan, to my far left. Dr. Khan is the Dean of the College of Public Health at UNMC and also has extensive experience working with the CDC in treating Ebola in Africa. Seated next to Dr. Khan is Dr. Bradley Britigan, Dean of the College of Medicine at UNMC, President of the Nebraska Medical Center, and Dr. Britigan is also an infectious diseases expert and specialist. Seated in the middle is Ms. Rosanna Morris, our Chief Nursing Officer and Chief Operating Officer at the Nebraska Medical Center. And seated closest to me, I'd like to extend a very warm and personal Nebraska welcome to Dr. Mitchell Levy and Diana Mukpo, parents of our patient. So with that, ladies and gentlemen, I'd like to open this to your questions. We will take questions online and over the telephone as well. And who would like to start?
With somebody with the virus, or is it just too hard to tell?
Well, I asked him about that a lot, and he's not certain, but he was around the clinic. He was filming inside the clinic and around the clinic, so he had a lot of opportunity to be exposed. He does remember one instance where he was helping spray wash a vehicle with chlorine, and he thinks he might have been splashed, but honestly, he's not exactly certain.
How are his spirits right now?
He's enormously relieved to be here. Of course, it's still quite frightening, but he's hanging in and he sounds very strong. And I think he shares in the relief of the rest of his family that he's been able to come back for good medical treatment here.
How's he feeling?
He looks strong. He walked off the plane, gingerly waved to us as we saw him from a distance, wheeled into the room, and he, is tentative and frightened, but I think he's strong, and his symptoms are not more advanced than when I talked to him before he left, which is a real relief to us. He was on IV fluids before he left.
There are, by account, reports of 40 physicians and staff working on Mr. Mukpo, but we've got room for 10 patients. If it got to a point where we had 10, we were at capacity, what type of a staff would be needed to take care of something like that?
The team of 40 and growing, because we have had many individuals from physicians, nurses, technicians, other support staff who continue to want to volunteer and participate as part of the care delivery team. Really is set up so that we can create a 24/7 presence and the necessary resources for this patient. We have discussed our ability to assume more patients over the course of time, and we would evaluate the needs of those patients and what we would need to do to supplement the team further. But at this point in time, he is receiving very good attention, and we would reevaluate that option if it were to appear.
What's his prognosis, and are you considering experimental treatments?
I just ask you to pull the microphones just a little bit closer. There are some that is having trouble hearing.
So, I mean, with each one of these patients, therapy needs to be individualized. So we certainly are really considering all treatment options, and obviously will need to be discussed with him, because ultimately, if there are experimental therapies involved, he's going to have to be willing to and understand the risks and benefits of those.
What about the idea of a blood serum from someone who has survived Ebola?
Again, all things are being considered.
Do you think the way that Mr. Mukpo might be treated this time, of course it's still too early to say, it would be similar to Dr. Sekro's in the sense that we saw 3 different kind of components to that treatment, that it isn't just one drug or one serum?
I mean, I think it's going to be difficult to predict that. Certainly, the standard therapies of managing the fluids and all of the other changes that go on in terms of the blood electrolytes, as they're called, is going to be standard. You know, the other forms of therapies that will be considered, again, are going to be individualized to him.
What did you guys think when your son first went over to Liberia, knowing that his...
Well, I think we both had similar reactions. Our son is very strong-willed and determined and has always lived by his integrity. And he made a strong connection for the 2 years that he lived there with the Liberian people and their culture. And he felt compelled to go back. When he told me, I asked him if he was crazy. And obviously did everything I could, and I know Diana as well, to dissuade him. And at the same time, he made it clear that he felt like this is what he was trained for, and he really had to do it. And he felt that he understood the risks and that he was putting himself in harm's way, but that's how he wants to live his life. I still think...
How did you go over?
I'm sorry? Where did he go over? I think he went back over...
It's about the 4th of September.
Yeah, he had come home just in May from being there working with an NGO for 2 years.
What did you say to try to dissuade him?
I told him I thought he was crazy.
And I begged him from a mother's perspective. I said, please don't go. But there was nothing to do. He was determined.
I told him about the risks, what I knew about Ebola, and why I thought it wasn't a good idea, the difficulty of getting treatment once he got there, if he did get sick, all the things that any of us would tell our friends or our patients or our loved ones. And none of it worked, obviously.
I'm guessing you probably had this kind of conversation, maybe not Ebola, but maybe other things. I mean, journalists get asked that question
Sure.
a lot going into war zones, that
Yeah.
sort of thing. Have you ever had that sort of conversation before with him?
Yes. Sure, when he first went to Liberia to work for the NGO, he graduated from London School of Economics and Columbia University, and he went to work for an NGO in Liberia. I'm proud of him, and at the same time, I would prefer that he went somewhere safer as a parent.
What was he doing for the NGO?
He was doing writing and field work, looking at the relationship between the Liberian people and big industry.
Yeah, and the conditions of the workers in the mines.
Has he expressed any regrets or second thoughts now since what has happened? Or has he realized, well, I knew what I was getting into?
It's both. His first reaction was, I'm sorry I put myself in this situation for you guys. So his first comments were more concerned about what it would do to us. But I think, of course, he's probably of two minds. He has some regrets, and at the same time, he's still is proud of what he's doing, and I'm sure he will go back to doing things just like this.
Have you talked to Dr. Rick Sacra? Has he reached out to you and your family?
We have not spoken to him.
Looking on your son's Facebook page, he is passionate about the people of Liberia and getting them help and the recognition they need. Does that kind of show who your son is? He's just a big-hearted person wanting to make a difference in this world.
That is Ashoka in a nutshell, and we're very proud of that.
I would add strong will to that.
So Dr. Khan, Dr. Sacra did end up back in the hospital over the weekend. Is there any indication, although he was found to be Ebola-free, is there any indication that this virus is mutating in any way or might be changing in some way so that each case is different in the treatment?
Not at this point. So as you know, the patient who was initially treated here at the university was hospitalized briefly over the weekend, but was determined not to be, it was not associated with this Ebola infection, so it's a concurrent sort of illness. But there's no evidence of significant mutation, significant changes in the virus.
Who's going to take the
Dr.
questions
Khan,
on
when
the
we were
phone?
here a little over a week ago, Dr. Sacra said that it seemed as though the telltale signs of symptoms, some might be hidden, but yet we hear the CDC say that the symptoms are the same. Have you been able to figure that difference out? Because he thought that maybe they weren't the telltale signs when he talked to them.
I don't have the specific details of what Dr. Sacra may have told you, but with any disease, everybody doesn't have the exact same symptoms and they don't have the exact same progression. So that's why it makes it difficult to sometimes identify what's going on. But there are some characteristic conditions that you know this is likely to be Ebola. So, you know, we know they have had contact with a patient, they've had a fever, they've got headaches, they've got muscle aches, they may have a stomach ache, vomiting, diarrhea, that sort of progression. Then about 5 to 7 days, about half of the, and some of them about half will have a rash also. About 7 odd 8 days into it, then you could expect that maybe they may have some bleeding at some puncture sites, and then that's how their illness would progress. But again, it's different for each individual person.
Doctor, how much of a help is it going to be in treating this case from the fact that you've already treated Dr. Sacra, the experience gained from that?
Well, you know, I think it's clear that you can learn a lot about a disease from reading about it in journal articles and textbooks and things, but there is really no substitute for firsthand experience in terms of taking care of those patients. With the caveat, as Dr. Khan said, that, you know, every patient is different in terms of the course of their disease, how they respond to different treatments and things, but having experienced this in one case, it's going to be very helpful.
Does your team feel more comfortable because of that experience?
Yes, and certainly, Ms. Morris can probably comment on this as well. You know, we did gain some understanding about some systems improvements that we could make that accelerate our ability to get laboratory tests back in a timely fashion, and some other things that have been implemented and are now part of the standard procedure in the biocontainment unit.
We have many, many questions on the phone, and so we're going to start to take one or two from the phone, and because they're not here in person, when you answer, if you don't mind, just say, hi, I'm Dr. Britigan or whatever. So who's the first question from the call-in?
Yes, this is Catherine Welch, Rhode Island Public Radio. I was calling firstly to see if they know how he got Ebola, and secondly, what are his symptoms now?
So this is Mitchell Levy. As we mentioned before, he's not quite certain how he got infected. He thinks that might have been an episode of when he was spray washing something, where he might have gotten something sprayed on him. And his symptoms are the same: fever, a little bit of nausea.
Other?
Yeah, can I ask a question? Hello.
Please.
Hello, hi. My name is Yeshi Doji. I'm at the Voice of America Tibetan Service. Because of his connection with Tibetan, I'm really interested to know more about it. Also hear from his mother, Diana Mukpo, about his condition. I'm also wondering if he's going to receive the treatment, the medicine, the experiment medicine that was recently used.
We're really happy that his symptoms are not extreme yet, that he's arrived here still in the relatively early phases. He seems to be in good spirits. And we're still in a process of discussing with his physicians and the team who are taking care of him which medications they're going to give him at this time.
This is a question for the parents. Have you been able to speak with him since he's arrived? When Dr. Saker was here, was able to video message with his family. Can you talk about that a little bit?
Yes, we were able to speak with him shortly before we came down here through the video cam, and it was an enormous relief to be able to see his face.
Will you be able to continue to? How often do you think you'll be able to talk to him?
I think as often as he and we want to.
Yeah, he's tired, and I think he wants to rest. So we talked with him, and then we let Helen talk with him alone for a while, and then he called us back in and said he wanted to rest. But it was really wonderful to see his face.
Was there even a chance that Ebola would have occurred? I mean, they tested him in Massachusetts for Ebola, but he was cleared by the CDC last week. Why would they test again to see?
They probably, Ali Khan, they probably tested again for an abundance of caution. We have significant clinical experience at this point, and you seem to be immune, at least probably for up to 10 years after you've been infected with Ebola. As we have previously said, once you have recovered from Ebola, you may still secrete a small amount of virus in semen and breast milk, and we tell patients after they recover from Ebola to take appropriate precautions to make sure that there's no secondary transmission under those circumstances.
How closely are you working? It's 3 facilities right now in America are dealing with Ebola patients. How closely are you working with each other to teach them what you've learned and learn what they've learned?
Extremely closely. So our medical team is in constant contact with other colleagues across the United States, and not just across the United States, but worldwide. So this is not just an honor to take care of Ebola patients, but there's an obligation here to take the information and share it with the global community so that it can be used where this disease is hitting hardest, which is in West Africa. And that's where the people need the best lessons to try to make sure that they can take care of whoever's coming into their doors. It's not just the medical care. We also need to remember the public health component of a good, strong response. And how can we take the lessons we're learning here at the University of Nebraska Medical Center on how to protect our employees, protect our patients, and protect our communities, and share those lessons back, not just in Africa, but worldwide, including here in the United States. So we are more than glad and anxious and willing, and have been reaching out to, or as others have reached out to us in hospitals across the United States to say, how do we protect our patients for us to be able to share our best practices with them?
Dr. Khan, is there any way that some of your people here at the Nebraska Medical Center could go overseas and help patients there, or even give your medical experience to doctors in Liberia?
So, do you want to
We have been in, it's probably a good one for me, we've been in near constant contact with people across the world, and particularly in West Africa, in Texas, et cetera, several times a day. And what we've done is set up some telemedicine type linkages that allow us to communicate directly with both video cam, and this way we can be in multiple places simultaneously. We've not ruled out people traveling, but it seems most efficient to have them centralized here where the technology is the highest, and then connect electronically worldwide.
Would it almost be like a video conference inside a hospital there?
That's exactly what's been going on.
Dr. Khan, this question is for you. And you talked about a little earlier about the lessons that you guys have learned about, treating Ebola and dealing with it. Could you expand on that for me, and what the hospital's kind of taken away? This is twice now, from this learning experience.
Let me turn that to Dr. Britigan, who's our Dean of Medicine.
Yeah, I mean, I think that, in particular, the importance of particularly hydration, giving lots of fluids, and monitoring the blood chemistries very, very closely, because they can change very rapidly, I think has been part of it. Symptom control to make the patient comfortable has been another. And then, as I mentioned earlier, modifying some of our laboratory procedures to make them more efficient and safe for the individuals who are carrying out the tests as well.
And when you say modifying, what exactly do you mean by that?
Well, in one case, in the most significant case, we have taken some of the laboratory equipment that was in a off-site location and moved it into the biocontainment facility, so it is right on site. We don't have to move specimens out of the facility. The testing can be done literally feet from the room of the individual being treated.
The virus was caught in the early stages, so is it possible that his symptoms will become more severe before improving?
That's my understanding, yeah.
That
it's likely that he will go into the next phase where his symptoms will get more severe. But remember, the number of people treated here is still very small in the West.
How often is staff checking his blood and vital signs like that?
We have 2 nurses in the room with our patient at all times, and it's dependent, but vital signs, for are being taken at a minimum, usually every 1 to 2 hours. Lab work has been 3 to 4 times a day. So it's dependent upon the needs, but we have staff readily available to be able to produce those necessary tests as needed.
And Dr. Levy, you mentioned your son thinks he may have caught it when he was splashed cleaning out that truck. How soon after that did he start showing symptoms?
I don't remember. It was a vehicle that someone had died in.
The incubation period is typically 2 to 21 days, and many people get infected around 8 to 10 days after, manifest symptoms 8 to 10 days after they've been infected.
This is obviously a very serious situation, but I'm wondering if any of you think that the media coverage is overdoing it or underplaying it, the risk.
Maybe that's for me as well. I'll take a shot at it. I think it's been pretty appropriate. Our experience thus far is that the media has been very, very respectful of the patients and their family. I think there's a lot of global concern, and there's also concern in the communities in the United States. High-quality information is what we're all about sharing, which is why we're gathered here with you this morning, and we'll continue to do so, by the way. So I'd say the balance feels pretty good to me so far.
And that's here at the University of Nebraska Medical Center, as the Chancellor has outlined. Globally, you have a critical role in helping people understand the magnitude of this outbreak in West Africa. This is where the real tragedy is, and this is where we need to have a robust global response to help the people in West Africa. And domestically, the media plays a critical role in educating people to help them understand this new disease. The concern we're hearing in our communities in Dallas, for example, and other places where they've had suspect cases is very understandable. It's a disease, it's brand new to the United States, and we need to help people understand those that are of concern and those such as Ebola, where we know how it's transmitted and how we can prevent subsequent infections to help educate. So we really do need to help educate our communities and help them understand it's not just healthcare, but public health that comes together to protect our communities.
Doctor, hypothetically, if the patient received or got the Ebola from being sprayed while cleaning out a van, is it possible that another person might have also gotten sprayed and not contracted Ebola? In other words, if you're exposed, are you 100% guaranteed to get it, or does it depend on the patient?
I think you answered your question already, but either Dr. Britigan or I can sort of answer it for you also.
Yeah, I mean, with a lot of blood and fluid transmitted diseases, a splash on the skin, for example, the virus has to be able to penetrate the skin and then cause infection. And in not every case is that going to happen. But certainly, you know, that's the risk. And exposure, for example, into like the eye is probably more dangerous than on the skin, but everybody is different and every exposure is different. It's like how much blood, how much fluid, how much virus was there at the time. A lot of factors play into it.
Why don't we see if there's somebody else on the phone who may have a question?
Hello. This is Karen Ziner with the Providence Journal. Can you hear me?
Yes, we can.
This is for Dr. Levy, just to clarify, because we're having a little trouble hearing. Did you say that your son was spray washing a vehicle that someone had died?
Yes, he was disinfecting a car in which someone had died and working with a few people to do that.
Dr. Levy, this is getting way ahead of the game, but when your son recovers, will he return to Providence?
Will he return to Providence?
Yes.
Yes.
I'm curious about the costs, the treatment, the transportation, police presence, paramedics. Who pays for all of this?
I guess that comes back to me as well, and that is generally handled through, at least our experience with Dr. Sacra, this was a combination of different organizations, but the SIM organization and through the healthcare services that they provide for people who are doing missionary work pay for their healthcare services. And I'm sure that the people at the Nebraska Medical Center have worked this through, but I can't tell you off the top of my head the details of who.
Through with the patient's own insurance?
I don't know. Maybe his parents know who carries his health insurance. I
don't know.
If I could just add to that, I think costs are clearly an important area that we need to understand, but our primary focus, particularly at this point in time, is to provide the best quality of care, and there are others on our team that handle the financial aspects, and I'm sure it will be taken care of.
Is the hospital prepared to accept more than one patient at a time?
We have been in contact with the State Department, and again, we evaluate that on an as-needed basis. Right now, I think since it's so early, we believe that we really want to maximize our expertise one patient at a time. But again, we are prepared to discuss that moving forward.
It sounds like in Dallas, the problem was human error when they didn't read the checklist correctly or transmit the information correctly. What are the chances of something like that happening here, despite all of the precautions that you've taken?
So this is a distinct difference between what happened in Dallas, which is an uncontrolled situation of a patient reporting into an emergency room with Ebola infection, and what's happening here, which is a controlled situation where we know what the person has. There's another distinction, which is the training that has happened in this institution for the last decade to make sure that we have trained and drilled again and again that we can protect our patients, protect our employees, and protect our community. And that's combined with the practice to make sure that we can provide extraordinary care to these patients when they show up here at the University of Nebraska Medical Center. So that's a big distinction about what's going on here than what may have happened in Dallas. And again, our offer to be a resource just to the United States and worldwide as they think about patient management issues and as they think about infection control issues within their communities, so that other hospitals in the United States, when they see cases, and again, this tragedy as it continues to expand in West Africa, you will see cases, you will see individuals who will make their way into the U.S. and other countries. And we need to make sure that every hospital is prepared if somebody shows up in their emergency room with a severe infectious disease.
Dr. Khan, do you think every hospital is at this point? Because a lot of questions are being raised, not so much about what's happening here, but because of Dallas.
This question is best addressed to the Department of Health and Human Services of the United States that run the hospital preparedness program and state and local health departments. But I think the experience in Dallas proves that there's much work to be done in this nation to make sure that hospitals are prepared for cases such as this. Of the people who are currently being watched with the highest risk, I believe 7 of them were healthcare workers and 3 of them or family members, and the family members are quite understandable. But this, again, I want to take it back to the public health aspect. Our job is prevention, and so nobody should be walking into the emergency room who you don't know has had exposure to an Ebola patient. That person should have already been under investigation, should have been being followed up for 21 days from their last contact with an Ebola patient. So this is a failure of public health in West Africa that is making a global problem a very local problem for us here, whether it's in Omaha, whether it's in Dallas, or the next city in the United States.
This question is for the parents. Has your son expressed any interest in returning to Liberia?
Oh, I think that's the furthest thing from his mind right now.
I have a question for the doctors. Were you able to speak with Dr. Rick Sakra either recently or before he left about possibly coming back to help with this patient or any future patients because, you know, his treatment was so successful?
I don't know of any.
We've been in back and forth communication with Dr. Sakra and his family. I've not been personally involved, so I don't know whether that question was asked or answered. I know there was some concern when he was briefly hospitalized over the weekend, and we were very relieved to know that that he's been discharged and is in good condition. I think as the evaluation of our current patient proceeds and a diagnostic and therapeutic plan is created, we'll then see what pieces fit into it. And if that fits into it, we'll have conversations with all of those that are involved.
Has anybody been here to donate blood yet?
No.
This is a logistics question. Do you know why they're moving into airplane instead of optic, and was the same transport company used?
I can't speak to the decision around Offutt versus Epley, but I can say that yes, we did utilize the same teams that provided transport for Dr. Sakra previously, a little more scaled down than the first time, but they were pretty amazing again.
In terms of the people that were actually inside that ambulance, was it the exact same EMT's nurse, or was it different people?
I don't know exactly if it was the same individuals, but I can tell you part of the same teams.
Right now, it's way too early to tell how long the recovery period would be, but how soon before you kind of get an idea of, will he be here for a week, a month? Is there an exact point you could tell?
No, I mean, every patient, again, is going to be different, as was the case with Dr. Sakra, from the standpoint of being ready to be discharged and how he was feeling. That actually probably was earlier than when his blood tests were negative, and ultimately it's the negative blood tests that determine when somebody is going to be able to leave, assuming that they're otherwise doing well.
Did you both walk off the plane and walk into the hospital?
Well, we saw on the news that he walked off the plane and he was brought into the hospital on a gurney, on a stretcher. But he was up and waving to us and very awake.
We'll see if there's one more person on the telephone who would like to share a question. I guess not. Is there somebody else in the room?
Hey, I'm on the phone here. I have a question.
Yes, please.
Hey, my name is Matt Starker. I'm with CNN. Thank you for taking our questions. My question is, has any emergency investigational drugs been requested for use in Mr. Mukpo? I know Dr. Sakra received TKM Ebola. Have any drugs like that been requested for use with this patient?
As I mentioned earlier, this is Dr. Britigan. We are really, at this point, assessing all treatment options for him, and no specific decisions have been made.
Any other questions from our group here?
Does he believe there may be a chance that he may have infected someone before realizing he was carrying the virus?
I don't think so. The folks who are working on the ground, they were very hypervigilant, and that as soon as they develop any symptoms, they self-quarantine, which is exactly what Ashoka did.
So,
well, I think it was part of the work that he was doing and writing and videoing a lot of what was going on, and then just before he got sick, he started working with NBC News.
Can you talk about the specifics in the treatment and care Dr. Mukpo received, and how you would determine whether that is going to be similar route that you're going to take for this patient?
Yeah, I mean, so as you, I think, are aware, Dr. Sekra was, again, treated with a lot of fluids and kind of standard management of critically ill patients. He got convalescent serum therapy, and then he got an experimental drug on top of that. You know, so part of the assessment will be looking at whether or not those experimental therapies are appropriate to his particular circumstance. Every patient is different in terms of their, again, risks and benefits. You know, how he's doing otherwise, and what other, the availability of some of these drugs, which, as you know, ZMapp, for example, which was used in the patients in Atlanta, is not currently available. So all of those things have to be factored together.
Can you talk about Mr. Mukpo's current conditions and symptoms right now, how he's doing?
So he has some nausea, no diarrhea, still has a fever. So really, in many ways, his symptoms from the last time I talked to him, yesterday morning, I think it was, or I don't remember, just before he got on the plane, have progressed a little bit in terms of nausea, but not very much. And I think that's the really good news that we feel, that we had been really hoping that he was going to be air-evac'd before his symptoms became problematic, which is exactly what happened. He left before his symptoms became bad.
I think it's time to wind down. I promise you that we will continue to keep you all connected. I'd like to thank all the members of our panel, particularly thank his parents who have traveled far to be here and to give you their time this morning. We'll work hard to keep the communication stream flowing. I thank you very much for being here, and I thank you so much for respecting the privacy of our patients and their families. Thank you very much for being here.